think should we go ahead and get started?
Yeah, let's get started.
Well, I'm gonna introduce for those. I think we've got a pretty at this point we've got a pretty good following of people that join us every single month, and thank you for those that join us every single month. This has been fun to put on. And for those that are new and haven't ever been introduced to David Hornbrook, I want to introduce you to him. David is an internationally known cosmetic dentist, one of the best that are out there. People literally fly from all over the country to see him. I mentioned this as people were joining. He resides in Southern California, spends a good amount of time in Mexico. He is a tequila connoisseur, and I've learned more recently that he is a former exceptional swimmer. Are you still an exceptional swimmer?
No, I'm not an exceptional swimmer anymore.
I do triathlons, and David and I have been chatting about his swimming. I'm by no means a great swimmer. If you've not had the chance to learn from David yet, for sure check him out. His website is
Hornbrook.com,
and check him out. He provides such good content here, and then he travels the country doing live courses as well. So we're thrilled to have David on with us tonight. So thank you, David.
Oh, it's my pleasure. Are you done?
Yeah.
As Steven said, usually in San Diego or Mexico, depending on what time of the month it is. But I'm teaching a course this weekend, actually, an over-the-shoulder veneer course in Salt Lake at the university. And so Dental Intelligence, who's our primary sponsor with this course, is just south of Salt Lake. So I called Steve and I said, how about if I just sit next to you instead of 1,000 miles away? So this is our 20th Real Talk. And originally we did it because we couldn't do live education, and we've had so much fun with it that we decided we're just going to keep doing it. And, this is, there's no charge for this. It's live. You'll get CE, as Stephen mentioned, at the end. This is only made possible from because of our two primary sponsors, and that's Dental Intelligence, Dental Intel. A lot of you are familiar with that. If you're not familiar with Dental Intel, I would ask you to look into that, because you've heard me say it before. We changed our practice management software after 35 years using PracticeWorks to Dentrix, just so we could use Dental Intel. It's a credible program. And second is Utah Valley Dental Lab, which is a lab here in Utah that's our other primary sponsor, and we want to thank them. So without further ado, I want to introduce our guest tonight. A lot of you might have heard Matt Roberts speak somewhere over the years. He's a phenomenal person. I'll say that, number one. You're just a really good friend. We've been friends for, we were thinking, almost 30 years, right?
Yeah.
And again, it's an amazing person, amazing family. But second, he's an amazing ceramist, and third, he's an amazing educator. And Matt owned CMR Dental Lab in Idaho Falls, Idaho, just until recently, when his son Michael, who's next to him, bought the lab, and Michael's been real involved. And I've known Michael since, 10 years old, since he was like 10. And he's got a young son that is going to be a hooligan, probably like you were. So get ready for that. I remember those days when Matt would drag you along to the ski slope. But welcome to both of you. And this is going to be really fun. We've had some great education on veneers, on sleep apnea, on materials. The one thing we have not had is really the whole digital workflow. And Matt and Michael are masters at this. And that's, taken from the scan to the final product, literally all digital. And I think, Matt and I are, before we started, we're talking about, do I do much digital dentistry? And I scan, but that's about it. And so my digital workflow needs this program as well. And I'm really, really excited about this. And again, this is live. If you have any questions at all, as Stephen mentioned, please use the chat box, not the Q&A box, the chat box. And I'll be monitoring that. And so if there's any questions that I think are apropos to the time that I can interrupt Michael and Matt, I will. And then we'll move forward. And any questions that we don't get to during the program, we'll get to the chance to answer at the end. So use the chat box. Welcome, everyone. We got a good turnout. Michael and Matt, thanks so much for taking the time. Matt, you're one of the few people that I think is busier than I am, or as busy as I am. So I know stealing you for a Thursday night is a big deal, and I appreciate that. So welcome, and let's see what you got.
My pleasure, David. It's really a fun opportunity to get to visit with you here and share some ideas, and as well as with Michael, who is my new boss now. So things change. I'm really excited about digital dentistry, and have been for a long time. it seems like it's something new, but as I was pulling slides together for a presentation recently, I looked back and we were doing full mouth reconstruction using 3Shape software in 2012, and have been doing mostly digital work since then. Michael learned on digital dentistry and has been going hard at it for what, 10 years now, Mike?
Yeah, it's been about 10 years because I started in 2012 when you showed me the software, asking me what I thought of CAD dentistry. And as mentioned, this is kind of like what I do working for the government, designing fiber optics. It's a similar program.
Yeah, so that your background in laser technology and fiber optics certainly came in handy for us in the dental field.
Yeah, it was pretty nice.
Yeah.
Just stepping in like that.
Very cool. Well, let's look through the journey that we've gone to get into to dentistry. Can we go ahead and let's see if I can figure out how to bring the.
Yeah, just share your screen at the bottom, the green button.
There we go. And we still need the keynote presentation in play. Okay, are we sharing yet?
Not yet.
No.
No.
Did you double click on share screen? You clicked on that?
No, I lost my mouse. My mouse went away when I did the last.
Can you just scroll down to the bottom and that
Let's go here we go. Got the mouse back.
There we go.
Okay. I put it in presentation mode first, and the mouse went away, and nothing was happening. How does this look?
looks
Very
good? Looks relaxing.
Okay, yeah, that was our campsite, Gooseberry Mesa. We were down there mountain bike riding in southern Utah a year or two ago. Beautiful country, great place. So functional aesthetics in the digital world. What's happening in this area? Is it almost a new profession? We coined the term digidontics as a new specialty in dentistry. There is so much new stuff to learn and so many things that we can do with this that we haven't been able to do previously, that I'd like to just kind of go through it and see how we're using digital technology today and how we're integrating this into the predictable workflows that David, you and I spent years developing practical, workable, step layered upon step of sequencing large aesthetic cases so that we didn't have any surprises or gaps or leaps of logic in the whole process. So digital impressions are certainly something that everybody is seeing and many people are using today, whether it's intraoral scans or laboratory scan models. The digital data can be entered into the system directly with iOS scans, or you can send conventional impressions to your laboratory and the laboratory will digitize the material more than likely. We're using outputs for digital design of digital milling. We're using digital 3D printing. We're using digital photography, and we have been using digital photography for a long time, but I do still have some 35mm slide carousels with 3 screen presentations tucked away in a corner somewhere in the lab that I used to have to lug around with me when I was lecturing. Much easier off of a Mac and a projector. Digital X-ray is certainly being used and has taken over in cone beam CAT scan. We see 3D data being integrated into crown designs, into implant placement, into surgical guides. But let's just look at a few examples of this. I'd like to kind of break this up into what are the tools that we have, and then walk through what digital workflow looks like on a typical aesthetic reconstructive case today. And then we'll go into some other areas and uses for digital workflow and some variations, and also some of the special things that we can do with digital workflow, like if we have a prep bite mounted to an opposing bite, how do we verify if that bite registration is taken in the correct place? What are the visual clues that would tell us that this might or might not be right? And if it's not right, how can we remount virtually to the correct position? And what are the parameters that we would consider before we would do something like that? There's a lot that can be done in that category that makes big cases easier than they used to be. So digital restorative design is the language that we speak that works with all of these other components written above. So let's look at a little bit of an intraoral capture with Dr. Frank Scholl. He's scanning a patient. The patient's holding the iPad that we're seeing the scan virtually in real time. He can edit on that iPad, or the data can be transferred to a laptop sitting out in the hallway. If Frankie doesn't scan the case and we get a traditional impression in, or if we simply want to digitize something that we have as a model, then Michael would scan it in the laboratory using our E4 3Shape scanner. And not only can we scan models with this, but as you'll see here in a minute, we can also scan bite positions, which is a huge tool that we've maximized the use of. So you don't have to understand this at this stage of the game of why this is important, but store this little video clip away in your mind and we'll pull it out in a little bit. Michael, do you want to jump in here and tell us what you're doing with this?
Well, it's actually Maria that's doing this, but currently she can fit the entire articulator into the scanner and scan the bite position of the temporaries. And we're capable of lining up the temporaries to the hand articulated mounted position, if that makes sense.
Yeah. Or the bite registration mounted position, either one.
Yeah.
This is a tool that we'll explain the use of a lot more in a little bit. What Michael and Maria are doing right now is capturing the bite position, scanning on a full arch articulator. And then we'll take the individual scans and bring those in. And by selecting common data points, we'll superimpose the upper and lower arch into this new bite position. And then we can capture that and move forward and restore to that position. I'll show some cases that we've done this with, but we have clients that literally don't try to get a prep to an opposing bite, especially if they've prepped the whole arch. As long as they've adjusted their temporaries perfectly, they may have us mount to a provisional position digitally. And this is kind of what that looks like. You'll see more of this later, but as Maria puts data points here, you'll see the last piece fall in place here shortly. So now we have.
Matt, what would you, I know that you can do this, but what would you prefer as a ceramist? And would you prefer a bite of prep against opposing, or?
It's a great question. And what you're seeing right now is a cross-sectional analysis of this, and we're seeing perfect contact with the opposing arch of the provisional restoration. So our gold standard of checking a case in is when we see this alignment of provisionals. Because if you think about it for a second, the bite registration is taken from prepared tooth to opposing arch, whether that's prepared teeth or just unprepared dentition. That's the relationship that we use for a bite. We use whatever bite registration technique we've been taught, whether it's CR dentistry or whatever philosophy you come from. That's the position that we have been restoring to in the past. And then we superimpose temporary models using something that you'll see in a minute, 3-point alignment, over these prepped models. And we look at how the temporaries integrate in that bite position. So if the bite happens to be off a little bit, you'll see one side of the temporaries open and the other side penetrating the opposing arch. a little bit, indicating that the bite is not in the same position as the temporaries are. So when we see that, we say something and call the clinician and ask if they would like to get the patient back, take the temporaries off, get a new bite registration to get one that's closer to where the temporaries are, or if they would like us to remount to that provisional position. We're getting ahead of ourselves a little bit on this discussion. We'll see a lot more data that supports this and some stories about cases with it, but that's one of our most powerful digital tools. David?
And David,
Oh.
I want to also answer your question as well. It depends on how the records were taken. If the temporaries were adjusted in and the patient is currently comfortable in that position, then I would be happy with that, either taking a bite or going to the hand articulation of the temps. But sometimes patients aren't fully adjusted in and aren't quite comfortable yet. And there was a CR bite that was sent with the case, and then we would want to go more with the CR bite. So it just depends on how the records are taken.
Yeah, it's a clinical decision that the doctor makes. We provide the information to say we can put it here or here. It's very much the same thing when you and I were doing a lot of full mouth reconstruction together and we were teaching it back live. We would use wax injection over the prep model, and we would look at the initial injection position of how that came together and say, yes, this is right, exactly how it looks in the mouth, or ooh, we're hitting like the patient's a little bit in protrusive or excursive or stuff like that. So it's a real quick analysis of all of the data being consistent with the patient, and it gets us out of trouble before we get into trouble in many, many instances.
Okay, awesome.
Okay, we'll move forward. So this is Frank just looking at the data he's getting back.
So we can easily take the models off and interchange them through the magnetic mounts. Then we also have, this is the rendering from the digital design. So this case, you can see this is an additive, reductive digital design. And you can see the gray parts that are sticking beyond the white proposed position of the teeth are the areas that I'm going to have to reduce more. So this is a case where we have quite a bit of rotations that we're compensating for. And then we also have our photos on our larger monitor that we can also reference back to. But this is very helpful. It's almost prescription reduction. There are areas that if I'm trying to get to where my printed diagnostic models are, this is going to be a prescription of where I need to reduce more. So it's very helpful. And then we have...
So we will go through that concept more as we're walking through digital workflow on a case of how we communicate that data back and forth. The 3D preview, like Frankie was looking at, is a very useful tool. We also take cross-sectional analysis screenshots and provide a report on any diagnostic design that we did. Things that we can do with digital that we can't. I'm lecturing in Chicago. I get this email from the lab saying that Dr. So-and-so has a difficulty with the case. We didn't have any place to put it on your schedule when you get back. Do you mind designing a case while you're in Chicago? So the little email attachment you see up in the upper corner of the email is actually the case that I can drop into 3Shape. The design on the right-hand side of your screen is sitting down doing the actual digital design, and the email on the bottom left of your screen are the STL files from that digital design going back to the milling machine in our laboratory. So the potential for productivity is amazing, and it transcends spatial orientation of the different players in the equation. It's like our Zoom meeting tonight. We have people from all over the country and all over North America watching this. And we can also be working together in the same way with digital transfer of data. Kind of fun. This is a case that we did a diagnostic wax up on in 2014. And this was, I don't know, a year and a half ago. Do you think any of the tissue may have changed since 2014, David? Or do you want to still work with that wax up? If you're going to prep the case.
I thought some of the dentistry might have changed.
Yeah, I think a lot of things have changed since then. We'd done a wax up, but I'm prepping the case tomorrow help. And this is from Frankie Scholl in Lexington, Kentucky, or Lexington, excuse me, South Carolina. So Frankie's prepping the case tomorrow. It's midday in Idaho Falls, a couple thousand miles away. What can we do? I said, well, Frankie, did you take a digital impression of it? Yes, I did. So he transferred the digital impression to me. I did a digital design, sent him a quick just cell phone picture of the design in the mouth. We went ahead and generated STL files of that digital design that were printable. And we sent him the STL files. He happened to have a Moonray printer in his office, and although the surface morphology is slightly different than comes out of the printers that Michael uses in his lab, it's still very functional for making provisionals. So at the end of the day that he communicated with me, he had STL files back to throw in the Moonray overnight. The next morning, he post-processed the case quickly and made a Siltec for it. He could still go ahead and prep the case and provisionalize the patient.
Hey Mike, what you doing?
Loading up the milling machine.
Wow. Okay, putting jobs in the mill?
Yep.
Really? Cool.
I torture Mike leaving this section in, one of his favorites, but there's many of the functions that do have cell phone applications, whether your milling machine currently does or does not. Some of your printers do, and there's a lot of communication back and forth, again, regardless of where you're going to be. Mike, you want to add anything?
Yeah, that was back when we were beta testing the VLAN Select hybrids. So I was using TeamViewer as an app on my phone to load them in and start the cases because we're having so many issues with them finishing the mill. But as a way to monitor it, it's not really a practical way of setting up cases on a daily basis. You still need a mouse. But yeah, I was doing that on the lift.
So our milling capability in the laboratory involves using VLAN hybrid selects that Mike just mentioned, or and they're a puck milling machine, or they can mill individual blocks of lithium disilicate. So here we're looking at the mixture of zirconia pucks, wax pucks, PMMA pucks, and all of those have nesting software that organizes your restorations to where they mill out. The PM7 is our workhorse today. Both of these machines mill wet or dry, and there's many other manufacturers that also make good milling machines. This just happens to be what we work with. And both of these are 5-axis machines. Zirconia is kind of interesting in that when you mill it 20% larger than it's going to be, and it's calibrated for each individual batch. There's a barcode on there that tells the milling machine how much oversized milling to do. And then when you center the zirconia, the shrinkage and centering makes it fit perfectly when it's done. So it's kind of cool technology. And it's something that 10 years ago, 15 years ago, I didn't think we would be using much. Today, I can tell you that we're using as much zirconia as we are lithium disilicate restorations, and we're loving the aesthetics that we're seeing out of those. So what do we mill with the toys that we have? We mill a lot of Emax in the blue form. We can also mill PMMA, which can either be screwed and pressed in thin restorations, or simply used as provisionals or prototypes. Many different applications for PMMA. Those are some old school layered zirconia. What I can tell you about layering is that we don't do much of it anymore. I'm finding the aesthetic level that we achieve without layering is very comparable to what we can do with layering, but instead of having 85 MPa in Sisal edges, we have 850 MPa in Sisal edges. This is what the blue block looks like when it comes out of the mill. You can see the 6 little blocks, and Mike, you can tell me if that's the Hybrid Select or the PM7. I think that's the HS, isn't it?
That's a Hybrid Select. Yeah, that's the old one.
Yeah. So those are milled restorations in a final case of, again, blue block Emax, monolithic translucency gradient zirconia. We happened to use one called Multi-MT from Ivoclar, but there are also Katana from Noritake has equivalent products that are very pretty. Argent, I think, is making some now. There's almost all of the players are getting into the game. But what you're looking at in this photo is monolithic zirconia. There is no cutback and there was no powder used to make that. And we'll show some more of this later on, but that's become a very, very useful tool in full mouth cases. PMMA we use as prototype for all on 4, or in this case, all on however many there are there, all on 8. We verify fit, we verify aesthetics. It's a try-in before we make the case out of zirconia. We can go ahead and modify our ridge to whatever situation we want. We may plan on doing some grinding on that. If we're doing abutments, we do a hybrid type situation where we color the zirconia intensely before we center it. We infiltrate color into zirconia to try to match the adjacent prep teeth so that any pressed ceramic restorations around there that pick up prep color will pick up the same color from the abutment that they are from the adjacent prep teeth. So a lot of zirconia hybrid type abutments we'll still use if people are willing to do a cemented abutment. If they want screw retain, then we usually switch over to the 800 MPa multi-translucency zirconia. Micro-layered zirconia, you can do a lot in 2 or 3/10 of a millimeter. Again, as I said before, we're using this less and less, but there are pictures of a case or 2 in here, so I threw the category in still. I think there's still a lot of labs that are sticking with that. Multi-translucency PMMA for no prep overlays is a wonderful way to preview cases. Printed diagnostic designs we can either do on the carbon. This is a simple printer that we used to use, the Formlabs. And Michael, tell us about our other printer that we're working with.
Well, mostly we use the carbon right now, which is an amazing printer. It's a continuous build. So in something that would take this Formlabs about 5 hours to mill, it can mill, or to print. It can print in about 1.5 hours. We also have the Asiga, which is another nice printer. The difference between those 2 printers, quality-wise, is about the same. The carbon you pay an annual subscription for, and it never breaks. And if anything goes wrong with it, carbon actually calls you and tells you something's wrong and shows up and fixes it. Very nice. The Asiga, you bought it, it's yours. So,
yeah. And the Asiga is about a $30,000 printer. The carbon's about a $150,000 printer that you don't buy, you lease.
Right.
But interesting combinations. Either one of them print a diagnostic design. This is our diagnostic wax up now. We'll print and we'll put a little bit of surface morphology in until we have the texture that we want. But digital design diagnostic wax up is the standard that we work to make provisionals and work in the mouth. Printed models with removable Geller style dies, we do on most cases. In this case, it was done with the Formlabs, which isn't really accurate enough to do that well. The carbon, however, is very accurate for doing that. You get really nice tight dies. Impression scanning and printing models can be done. I don't do this a lot. We keep sticking our toe in the water with it. But the place that is really valuable is that impression that you get in and you look in the impression and you see the little piece of impression material that's just kind of waving in the wind, is barely attached, it has the margin running across it. You know that if you're going to pour stone in there, the stone's going to move it, you're going to see some distortion, and you aren't going to get a second pour on it. So anything that looks like it's going to tear or we're not going to get a second pour, we will go ahead and scan the impression first and print a scan model of it. And that's, for me, is my best use of it. I know some other people are scanning all of the impressions they get in. My solution to that is intraoral scanning. So
Funny thing today, Dad.
What's that?
Saw a case today that I'm all checked for you. There was a case, and I won't say whose, but where he kind of hit the tray, and we weren't going to get a second pour out of it. So we did an intraoral, or we did the impression scan on it, and then we poured the dyes. And then I had Teresa line up the dyes. They fit perfectly, as if it was just a second pour. Yeah. So, I mean, it does work as long as you can see everything by looking down to the impression. If there's anything going around any corner, then it won't work.
Yeah, well, and we've got a great support team for digital too. They can take stuff out of 3Shape and into third-party programs and do things with them that combine different pieces in different ways and come up with something that's very, very usable. So that's a wonderful resource too. Teresa's awesome, and so is Don. When we start talking about implants, for years, I absolutely hated getting implant cases in, because what was happening? The screw was always coming out in the wrong place. The tissue was always at the wrong level. And the instructions were, just make it and make it good. This is what we have to work with. So I'm absolutely delighted to see the trend in dentistry now of crown down designing for implants. Our workflow on this is design a tooth, because that's what the patient actually is coming to you for before the implant is placed. Take the tooth into a 3D CAD planning software and go ahead and position your implant for the correct biologic width from the margin of the tooth, and control your tissue level and come up with something that, when it's all done, actually does look like a tooth. It's a wonderful concept. It requires doing cone beam and working in the Implant Studio program with the 3Shape software. We'll design first in 3Shape if it's complicated design, or Implant Studio has some rudimentary design capabilities for crowns too. But when it's all said and done, we'll send out a surgical report that has the position of the tooth, surgical guide that results in the implant being placed in the right place, and you know, the sequence of events and materials and parts that we're going to need to go with the case. So it's, oops, sorry, I clicked on the wrong thing there. So here we have surgical guides. We'll go into a more in-depth case of surgical planning. That's kind of fun here in a little bit. That's the carbon printer that Mike was referring to, along with the curing unit sitting on the bench there. The PM7 ovens and the zirconia curing ovens are sitting there, along with one of the Bieland ovens off to the right behind the pictures on my screen. So let's look at the potential of today's all ceramics. Let's look at risk management. This was a pressed over zirconia restoration. We thought this was going to replace the PFM crown in dentistry about 15 years ago. It didn't. We saw this too many times. But if we think about it, we have a 1200 MPa core material that is very opaque, that requires quite a bit of layering over the top of it, or in this case, pressed ceramic. This was during the Empress era. But the pressable ceramic that went over the top of it is only about 85 to 100 MPa. So it wasn't a good match. We did see some fracturing in it. We ended up repairing some of those by putting lithium disilicate over it, or simply replacing. So let's talk about the strengths of the different materials that we have to work with. Feldspathic is pretty much any powdered porcelain is 85 to 100 MPa. Lucite reinforced which would be Empress or Authentic, I believe, was the lucite reinforced, about 165 MPa. Lithium disilicate, with the newer lithium disilicates like Emax, we see 500 MPa. I don't see anybody doing aluminous crowns. As a matter of fact, I can't even remember an example of an aluminous crown. David, can you?
Procera as a core.
Procera was, yeah.
And Woolsteram was another one.
Yep, there we go. So 600 MPa for the core material, but then again, with either of those, you had a powdered material coming over the top. The translucent zirconias are all over the map. Noritake has some that are super translucent that are clear back down to 500 MPa, and some of the new multi-layered materials that a couple of the companies have are clear up to 1200. But the good looking ones like multi-MT for Ivoclar is about an 850 material. And I really like that particular sweet spot. High strength zirconia is opaque in its original form, but getting more translucent as they're doing 3Y to 5Y color gradient in the formation of the pucks with the zirconia. They're coming up with some pretty strong materials that do have decent translucency in the gingival half and are fairly aesthetic. If we look back at Van Thompson and Petra-Guess, layered versus monolithic with, this is with Emax, we see that about 350 newtons, we start seeing failure with zirconia and feldspathic. We see that we can go up to 1,000 newtons on a lithium disilicate crown that's monolithic, and an awful lot of repetitions on that. It's just so much more durable in the mouth that we're seeing it used a lot more. So motion fatigue testing, as we were just saying, again, we're getting very high numbers in for the lithium disilicate, getting close to that of what PFM is, and wear compatibility is similar to enamel. We've been using this for a long time and we've seen pretty good results. We have seen in thin restorations over discolored preps, we see more show through than we would like. And I think David can speak to using lucite reinforced ceramics for some applications there. Can be pretty, if the right ingot is chosen or millable block is chosen for lithium disilicate, you can get similar aesthetics to what you get with the lucite reinforced porcelain, but there's a good conversation there. David?
That's a good conversation. Well, you know where I'm at. Empress is still and always will be my favorite ceramic.
Uh-huh.
Ivoclar in all their wisdom discontinued it 2 years ago. You know, we have to think about it. And you know, you're one of a few, in my opinion, that can make Emax look close to Empress. I think a lot of ceramics struggle with that. And I think a lot of our viewers would say they've seen Emax anterior cases that gray out a little bit, especially with ruddy complexions or redheads or strawberry blondes. And so you just got to be careful with that. I mean, you've seen that, you know, you've probably had to redo some cases where it's just, you pick the wrong ingot.
Yeah.
And you know, another one, and I think you and I haven't really had a conversation, but you know, we're using Lisi Press from GC, which actually looks in our photographs like Empress. So the thing I struggle, because I did so many Empress cases over the years, someone would break an existing veneer on a central or lateral to try to use Emax to blend into that. I mean, I struggled with that. You know, we'd go through a couple different ingots, and you know, you've had to go through that as well.
Yeah.
I'm just finding Lisi Press looks more like Empress.
Yeah. That's cool.
Empress still, if I had, I mean, you know, my teeth are still Empress from 1999.
Yeah.
If I had to redo them today, I would choose Empress, but I can't. So yeah.
Talk to Mike. He may have a few vials of it.
Yeah, you got some,
away in a drawer.
You got some 1 ingots in a sleeve somewhere. I'll take them.
Yeah, I have some in a drawer right over here. Anyway, And again, if we are going to layer, we want to do it in a very minimal amount. We want to keep functioning surfaces in the stronger pressable material and leave just the facial and sisal in layering porcelain. And we'll see some cases that we did this type of approach to today. We also need to still keep function in mind. And this is looking at canine guidance and where forces are focused by a small contact zone. We want to broaden that out a little bit. We want to look at balancing interference, and all of the things that we need to consider functionally don't go away just because we're using stronger ceramics. And that will prevent chipping as much as anything else will.
Hey, Matt, I'm going to interrupt you because there was a question earlier that I thought was kind of premature, and I think that might come in. So, I mean, what you're doing now, we've been using forever, right? Articulating, adjusting it out, whether it be in wax or ceramics or PMMA. Since you're doing digitally, so let me just, I'll ask the question. Is there currently a way to image in multiple positions with existing wear patterns matched up to create a functional jaw tracking digitally, almost like a custom incisal guide table that you would work with traditional analog workflow?
What we can do is take the preoperative teeth and superimpose them over the new design. And instead of following the pin that's out in front, that's a reflection of what those teeth are doing, we can actually follow the teeth. So we can occupy the same time and space with the two data clouds and superimpose them precisely. And we can then morph to that if we want to.
Okay. Can you move? Are you using a digital articulator as you're doing?
Absolutely.
Okay.
You'll see a lot of it. We can take the digital articulator and line it up like a face bow with the photograph and or a 3D face scan.
Yeah, and do you have the option of changing the degree of the condylar element too?
Absolutely.
Traditional. Okay, cool.
Yeah, absolutely. So lots of variability in there, and lots of technique to pay attention to. We'll show a little bit of that today. It's not a deep dive into that end of it, but be happy to share ideas on that.
So I'm gonna, again, because I'm curious too, and I'm interested. Like, I think if I probably am interested, hopefully at least one other person is as well. I hate to interrupt you. So, I like models, right? Not necessarily on single posteriors, but if I'm doing 10 veneers or if I'm doing a full mouth rehab, I like my models. I like to see the restoration on models. I like to see them on articulate, right? We're still using stone and we're mounting the key. So I'm not even gonna say we're using stone. We're using stone to maybe mount the printed models, right? But we're still going back to either a Panaden or a Stratus. So for those docs that you're doing everything digitally. So Mike, you're designing it, the wax up digitally. We make the provisionals. We take digital impressions on everything. And you're sending those units back. I'm assuming you're sending printed models as well, because I know the docs that you work with, they want to see it as well, right?
Right.
Are you mounting that? Are you mounting our articulator?
Yeah.
So they're getting it back and they're putting it to their Stratus or their Panaden or whatever they're using. Okay. So you are mounting these cases.
Yes.
Absolutely.
Okay.
You can do it either way, but I like to see the case mounted. I like to verify that the contacts are good. I like to verify my occlusion. I usually don't have to change anything from the digital design process, but it's a way of looking at the case that we're used to looking at, that we're trained to look at. And for that reason, we continue doing it. If we have people that request not to get models, we can certainly do it without also.
It's a way to quality control the case before it leaves. It's so you don't build it on the printed models anymore, but use the printed models to quality control it.
Yeah, to verify.
Yeah.
And because the doctors like to see their preps.
Yeah.
I say,
Exactly.
people like me that like
Sometimes.
to go off on. Oh, look at that! I did a good job or not, right?
Yeah.
Thank you.
So the thing that we use the most is the one on the far left, the multi-MT. I'm sorry that cut off in the transition there. MT I don't use at all, although I don't have a reason for that. It just doesn't have the incisal gradient built into it. LT, low translucency, is the 1200 megapascal material and is very more opaque, as is the MO, the medium opacity. Both of those are more opaque. If we have to cover really nasty stuff, we can go to those and use minimal layering over the top, but they are a stronger material also. Again, not something that we use a lot of. This shows the applications of the different materials. They're showing, appreciated framework. I would never do because I don't want that much powdered porcelain on top of zirconia. Full contour anterior bridges out of 850 MPa material are very useful and very nice. Again, all of the different companies have materials in here. This isn't a program to push one material over the other, just the category of materials is looking at what's available from different manufacturers. The new Prime Aesthetic and the new Prime are both a new family of materials from Ivoclar. Prime Aesthetic is a 1200 MPa Y3 to Y5 layered material. Prime Aesthetic is in the same niche as the multi-MT 850 MPa material that we currently use a lot of, and we're starting to transition to some of that. We've been playing with it. It looks like it has some possibilities. I heard that Arjun's 850 material is also pretty nice. So if we look at the gradient of the new technology, it isn't a series of layers, it's a continuous pour that goes from Y3, which is more opaque and slightly stronger, to Y5, which is more translucent and not quite as strong. But when we work with monolithic aesthetics, using a combination of a multi-translucency zirconia material with internal staining, and then a good stain kit like the Mio system from Jensen is one that I commonly use today. That's the type of results that you can get from not layering. And so the incisal edge of that is a 850 MPa material versus an 85 MPa material. And if we look at this page, all of these restorations are various forms of monolithic. There's no powdered porcelain on the page. And that's something that we're doing a lot. I'll show clinical photos towards the end of this presentation that show that. So how does this process work? We do our digital design and we mill it 20% larger. Once we get it out of the milling machine, we do a little surface morphology work. We take a diamond disc and enhance the embrasure form, put our surface texture in, and then we stain into that chalk-like zirconia. And it's like a watercolor technique. Your stains penetrate right in. We add coloring to it because you can't see the effect of the stain. It's kind of like a blind guy doing watercolor with invisible ink to do this. But after you do it a few times, you figure it out. And when it comes out of the centering oven, you have some color gradient and you have some effect in it. Not super detailed, but you have the general translucent to chromatic shift from incisal to gingival. And then you add the Mio coloring and the opaque effects. It's a liquid layering process. Really, it's a very thin layer of porcelain that doesn't intermix. If I take my old stains and try to do this, I end up with something that looks muddy and it's kind of a mess. If I use the carriers that are in the Mio system, I can put the Mamelon effects and keep them right where I want. I can add enhanced translucency effects and keep those where I want and put crack lines in, etc. So all the stuff that technicians get excited about, that's with a little different lighting in Michael's room with his white box setup. So multi-MT zirconia with internal stain, and the coloring we see from an initially out of the mill with just a little surface morphology added, to staining, to centering, to layering with some Mio, and you end up with something that looks like that in the mouth. So if somebody told me that that was monolithic zirconia 5 years ago, I would have laughed at them. With the materials today, we're seeing stuff that I can intermix with lithium disilicate, and it comes out looking pretty decent. Maybe my lithium disilicate just sucks and I've taken it down to zirconia level, but no, just kidding. So let's look at some simple aesthetics. Emax monolithic case, minimal preparation, a little different in color between the two teeth and very, very high value. Those are the preps on the printed model. Restorations prior to staining and applying color. This is an opal ingot. It's opal 2. You see it if you backlight it, you get the opalescent effect from the ceramic. If you look at it with a little more backlight, it looks kind of cool. And when we put it in the patient's mouth, it blends in pretty well. I probably missed on the high side of the value mark on that, on those two centrals, just a little bit, but she was very happy with it. And we moved forward into a couple of other cases. So that was a case that was done by Dr. Frankie Schull. This is a case done by Dr. John Weston, a very conservatively prepped patient. If we look at our preparation design here, very minimal. We're still in enamel pretty much everywhere. And thin restorations using Emax. We end up with something that's decent for the guy. Those are probably, I think, 3/10 of a millimeter thick. We go to another patient, Kiana. She also had a little bit of gingival asymmetry. So in the process of doing this, when we're doing a diagnostic design, we can carry the diagnostic up over the tissue. We don't mark margins on this in the diagnostic phase, and we can create a template that can be sent to the periodontist to go ahead and do crown lengthening, or we can do chairside crown lengthening. We can look and see how far we're over the tissue. We can measure that with some measuring tools in the software. And you can see in several places on number 9, 10, and 11, crown lengthening was planned throughout. On 5, 6, and 7, it wasn't needed. 8, maybe a little bit to straighten that out. So diagnostic design, turning the opacity up on it looks more like that. Facial rendition of it is the photo on the right. Printed model, conservative preparation with the tissue changes made, provisional restorations, and final restorations. Again, really, really thin Emax digitally designed. I put just a couple of cases in here because people have a tendency to think you can't do thin dentistry with digital dentistry, but none of these were over 2 or 3/10 of a millimeter thick, and they were done in Emax. If it gets too thin, I'll mill it in PMMA and press it, but most of these were just milled in blue lithium disilicate in a PM7 milling machine. So if we look at Trey, again, not much preparation there, very, very minimal preparation. Pretty good tooth color underneath, so we aren't going to run into problems there. Where you get in trouble with thin restorations is when you have a dark tooth and you try to do a thin restoration on a dark tooth. That is much more difficult and usually doesn't work. So 6 anterior veneers. Again, you can see that they're fairly thin, and that's the case put into place. So if you want to see more of that, that's something that John published in the Journal of Cosmetic Dentistry. There's a couple of pages of the digital workflow that we use, and it's pretty well documented in that. So good resource for people. So let's walk through a comprehensive case from A to Z that Frankie and I did together. This is Julie. Let's meet Julie. Julie has had orthognathic surgery previously, and it didn't come out well. If we look at Julie's bite position, when she closes her anterior, she can't get her posterior teeth together at all. So we wanted to start off with communication between doctor and lab. Michael, do you want to jump in? I feel like I'm running away with.
No, you're fine for right now.
Okay.
you're wanting to talk about smile design and lining up the full face photo. So here is a Smile Designer. It's a 3Shape product where you can take a 2D image and make a 2D design to show the patient what the preview could look like. And it's actually a little bit more lifelike than even in 3Shape design.
So the beauty of this is it's fast. I can sit down and do what we're showing here in 5 to 10 minutes, and it's a quick communication tool. If David wants to tell me where he wants to put the incisal edge, instead of going to Keynote and drawing lines around teeth and trying to do it in Keynote, this is a fast way of designing. So the first thing that we always do is level the photograph, and then we get a template that we can move into position as a group of teeth, and then we can bend, stretch, pull, and symmetrically design. It has symmetry features in it that if you move one side of the tooth, the contralateral tooth also moves the same way. So this will just be a quick little video that kind of shows leveling the face. You can see me moving the dot on the interpupillary line on her left eye, getting the vertical oriented to the aesthetic plane. We're taking a 1 to 2 photo and using common data points. We're superimposing the 1 to 2 photo into the full face photo. This is something you can do that with the retracted photo also. And as we move this around a little bit, you can see the teeth superimposed. I don't use that particular feature with retracted photo as much as I do the full face photo. There's a whole group of teeth moving in. We'll go ahead and position those and then just kind of give you a tour of some of the things that it's capable of doing. You can stretch and pull and move things around. There's a ton of different tooth libraries in here. So notice that when I pulled on the distal of the lateral there and the distal of the cuspid, both sides moved at the same time. So we're lining this up to where we're promising something that's deliverable. We want to make sure that we have the tooth underneath where our design is. We can leave symmetric design turned on, or we can selectively turn it off if the two sides are not symmetrical. And then we can put a surface rendition in there. And if we mark the boundary of the lip, we can make it sit behind the lip like the teeth do. And we can change colors on that. Play with different tints. Again, minimally useful. This, I think, is a very useful feature. It's a swipe tool that shows the patient what they look like before and what they would look like after. With the fill in place, it's a cute picture from a lab standpoint, but it doesn't have a lot of value to me. But the shell design has a ton of value, and I'll explain why. If we're looking at these two photos, the one on the top left is cute for showing the patient and kind of nice information, but I can still see where the existing teeth are on the bottom right one. And I have the same boundaries on that. So I can align this to a 3D scan, which is the most important thing that we'll do. So we have Trios impressions, upper and lower of this patient. We have bite registration. We'll go ahead and take the initial design proposal. Computers don't design cases for you. This is what 3Shape suggested as we start. So there's teeth kind of all over the place. So let's move this. You have the best success with digital cases if you think of being a denture technician and moving already existing teeth around. Ceramists always want to carve on things and whittle on things and add wax to things. And really, if you look at these, they kind of look like teeth where we started from. And if we don't do anything to make them not look like teeth, they'll still look like teeth when we're done. So proportional scaling is a tool I use a lot that doesn't change the shape of the tooth, it just changes the size. And just positioning teeth like you see me doing here in the video. We're going to do a little faster time for designing here. I'll just slide the bar on this, but you can see I'm just positioning the teeth over the existing dentition and getting them close. I know the centrals need to be a tiny bit longer. I don't know where I'm going yet, but I'm just getting an initial design put in. Now I'm going to go back to the photograph and the 2D design that we used previously. And we're going to line up the interpupillary line again to straighten the photograph. And then I'm going to put horizontal and vertical reference lines in. I always mark the midline with a reference line. I'll adjust the interpupillary position until we get the horizontal and vertical orientation that we want to see for the face. We can then go ahead and mark a translucent area on the picture that follows the boundary of the lip. And in this particular case, I missed it just a little bit. So we'll go back and remark those areas, and I'll speed that up a little bit. Once we have that done, now I want to pick common data points on the photograph and on the 3D scan. So you're looking at the Trio scan. I just picked a data point that I thought was a common data point there on the mesial of 7, and again on the mesial of 10. And as I go back around to the back, we'll see that the first data point I put in, I had on the wrong tooth. And we'll see the outline in the black lines doesn't quite line up over there. I look a little more closely and say, oh, that's because we have it on different teeth on the upper and lower. So we'll delete those two. It's really important to make sure that your lines line up at this stage of the game, because this controls the position of your design from here on out with facially oriented aesthetics. Now all the teeth have silhouette lines around them in black. So that's perfect. We can turn our digital design back on with facial reference now. So we now have facially generated aesthetic composition going on. These teeth are way too big and still need to be moved and repositioned. And that's what I mean by zooming in or proportionally scaling. And as we move forward with it, we try to line up our midline first, and then we'll move outward from the midline until we have our entire digital design. We can also turn the translucency of our 3D design up a little bit, and we can see those 2D lines underneath. So we can make sure that we're following the treatment that we set up. And here's what that looks like. So starting with number 7, I'll bring that back into position. I may scale that, and I'm seeing 10 scale at the same time. And so it's just a matter of using everything that we know about aesthetics, but with a different set of tools. So we're lining this up, we're following the incisal plane, moving the teeth around, looking at the overall smile. And then once we have everything in place, this is a diagnostic design, so it's additive and reductive. Initially, just additive. And we can see the teeth are outside where we really want them in a couple of places on the cuspids. But once we get the preliminary design done, I can change the surface look of this and get a more realistic surface texture on it. And this gives us an idea of how this is going to look for the patient. So it's an additive only diagnostic design where we can see the teeth sticking through this in various areas. We can go ahead and change the rendition of this to be more of an opaque, not a colored. It's a monochrome. Now we see all the little red spots where the occlusion is high. We see where our design is intersecting the underlying tooth. So we can see that, maybe we can do 3/4 veneers in front, but we'll look a little bit more closely at that. I always send photos of this out. We'll then go back to the articulator, and we can use the facial photo to orient the articulator. Basically, it works like a Coyce FaceBo does, where you have an average value distance from the cuspid to the condyle, and you set up the anterior posterior plane based on photographs of profile photos, and then a straight on photo like you see on the bottom right, where we turn translucency up and we can see the condyles going into the ear and set that up where we want to. This will show it a little bit more in a video format. So you can change whatever type of articulator you want, and then we'll go for the correct distance from the midline to the condyle. We can orient that. I can also change VDO. I can change angle of condylar movement and amount of condylar movement. I can change the Bennett left and right. So now this is lining up the facial photo. You see turning the translucency on a little bit there. We're a tiny bit rotated. We'll have to correct that. That straightens it up. And once we get it in position, we can hit the play button on the articulator. So that's articulation orientation. Now we look at VDO on her. We had an end-to-end anterior bite that we were fighting with. So we wanted to look at what we were doing. There was a possibility of doing all the lower anteriors too, but they didn't want to do that unless they had to. So in the diagnostic design, we wanted to do a what if and close and open the articulator and see what we could do just doing the upper arch and then doing the molars on the case and not doing the lower anteriors. As I open this here, we can see that I'm at 1 millimeter open. I still have contact points on the central, the little red marks, but that looks too open to get good canine guidance to me. So we're going to close this back down a little bit. You can see in the upper left, that little window there, I'm changing the value now to 0.7 and closing it a little more. You can click through and then I'm locking it in that position. And that's where we decided that we were going to restore with her. So additive only model is printed for a prep through technique. So this has any place the tooth is sticking through. It's a combined output model that prints the new design and the old teeth superimposed on each other. So this will always fit in the mouth. There's not going to be anything that you have to remove to get the silicone matrix to go in the mouth. If you have a case like what Frankie was showing at the beginning of the show in that little video where the patient had the teeth sticking way out facially and you don't do a combined output file, then your matrix would never fit in the mouth until you prep those areas away. David, I see a question.
Yeah, I have a question. So, you know, if I was going to change vertical dimension, the patient I'd use a Freedom appliance, which is our deprogrammer.
Mm-hmm.
I'm sure there was an auto rotation. So, you know, there's a chance you open this case up and all of a sudden second molars are hitting, right? You know, if the condyle seats. So how are you taking into consideration that you're not going to have condyle seating when you open the vertical?
We're starting with a CR bite before we do our diagnostic. So this is a manipulated bite using an anterior deprogrammer to get the initial restorative position. And that's what I'm designing to right here. You'll see a clinical here in a minute of what that looks like.
How is the clinician taking the CR bite digitally?
You can scan it.
You scan it.
So you put in the deprogrammer and scan the open bite position like it showed in the first video.
Right.
Where we're lining up to the models to the two separate sides of the scan. So we have the articulator in the scanner, it scans one side, flip it, scans the other, just like you would do in the mouth, but you do it with the deprogrammer in place.
And then you're closing down the first point of contact from there.
Yes.
Or in this case, desired restorative. Yeah.
Good.
So, okay, you bet. So we'll go ahead and print a model of that. And then we're going to make a diagnostic model for the provisional restorations, and the provisional restorations are going to be prepped. So we want to just get the teeth out of the way, essentially. We also want to kind of look at where our design intersects the natural tooth. So on number 6, if I'm looking at that, that looks like that could be a veneer. if we wanted, or at least facial 3/4 crown. So I'm not going to massively reduce it. On the lingual, what I'm going to do is draw a line that follows where I want the prep. And this is kind of communication between myself and the clinician. It also, again, prevents getting a matrix that won't fit in the mouth. If I get more aggressive than the doctor does, then we have difficulties. So this is a virtual prep tool in 3Shape. They're modifying this at some point in the future to offer depth prep and some cool features that will be coming out sometime down the road. But for right now, it's a gross reduction tool that just reduces everything within the green line. So it kind of goes like that. And we end up with everything prepped but the linguals of the anterior teeth. Now we're going to superimpose a scan of the preoperative model over this. So we can always see where the teeth were by combining the two models, but I can get them out of my way on the design. So this is 3-point alignment. This is the most useful tool in 3Shape. So I'm picking common data points. This is why we always scan retromolar pads and palatal areas, always. And we'll go ahead and put the last 2 dots in, and I hit align, and we have perfect alignment. So it's an incredibly accurate system that now we know where the teeth were, we know where the teeth are, and we can move forward from there. And we can start learning some things about the case as we do that. So we have our diagnostic design, we have where the teeth are, identify areas that are going to keep the final matrix from seating. We know areas that we would have to have prepped, and they're very easily seen in the blue color now, that the distal of number 11 needs to be reduced before we make the final temporaries. But we'll see that communicated in many other ways. This is what your final diagnostic design is going to look like. We've done the lower molars and the full upper arch. If we do a Bellis 3D scan, we can go ahead and look at the case with full facial reference. We can also play with the articulator and the occlusal planes. Unfortunately, Bellis is not currently available in the 3Shape world. I'm not sure what the political situation is on that, but as you can see, it's a very useful tool. I think there are some other, Face Hunter is another scanner that's out there that you can do facial scanning. And it's kind of a fun thing to be able to do. So this is very equivalent to a face bow as far as having 3 dimensions, an ear bow position to work from. The thing I like the most about it is looking at the lateral view, seeing how protrusive and retrusive my smile is going to look relative to the lips. Kind of a cool thing. I hope they get that back into the 3Shape equation. So we can also look at our occlusion on the case, and I'm going to run this one a little faster. This one drags, but we can see the marks. It's like there's an articulating tape in there. Blue is our excursive mark, red is our centric, green is a interference. I want to see more canine guidance there. So I'm changing things a little bit, and we'll keep playing with that until we get it to where we want it. So occlusion is very, very accurate in the digital world. We see the same thing in the mouth that we see here. We'll stop when we get to where we're happy with the adjustment on it. So this we'll print a model of, and the difference between this and the previous one is we don't have the preoperative teeth in this. This is for the provisional restoration. The previous printed model is for a prep through technique, and we want to communicate with David or whoever we're working with where we need to prep. So if you get a wax up back, David, I mean, how do you know where the technician took away material and where they didn't? Oops, you're muted.
David, you're on mute.
We use what we call an arch aligner, which basically a reduction coping for the arch.
Yeah.
So they'll do an Essex suck down, they'll prep through that.
Yep.
And then I slide that on and remove. But you know, it's still, you're still guessing a little bit, but it's more accurate than we used to do when we were just guessing, right?
Yeah, for sure. So what we have here is the preoperative model and the new design superimposed over each other. So we'll take a series of screenshots, and these are the screenshots that go out to the doctor. So we see, for instance, I'm going to try to move. Let's see. Yeah, never mind. I was trying to get the picture of everybody out of the way where it wasn't directly over what I was doing on one screen. But if we look at a cross-sectional measurement, we see the two little dots. If you look on the left screen, they're about 1.5 millimeters up from the margin. And you see the cross-sectional image that shows the blue and shows the final black outline. It also disregard the vertical straight line that's further in there. That was the virtual prep line, and it has no meaning. But the two outermost layers of this are your new design and your existing design. You can see there, if you look closely, you're 2.3 millimeters thick in the gingival third of number 8. So you probably are going to want to prep a little bit in that area. 9, on the other hand, if you do a cross section and measure it in the same place, is already prepped for you. There's very little to prep there. You may need to put a finish line as your margin. So this will keep you thinking about where you're reducing and not just randomly doing depth cuts into teeth. We can see the little lip there that when we change the bite and the BDO, we want to get rid of that little blue lingual line, red arrow to it. We see a cross-sectional image of that. That's something I send the doctor. We're going to want to break contact between 8 and 9, but we're going to want to break it mostly at the expense of 9, because that contact between the new design is moved a little bit to the patient's left. That's something that we really want to pay attention to. And I may accent it with an arrow or simply have a conversation and write a report that goes out with the case. If we look at this closely, we see that 9 was lingualized a little bit. And we've got kind of a lateral contact situation there anyway. So a challenging area. If we look at between 9 and 10, that's okay. That could even be done without breaking contact. We have a little bit of preparation to do in the gingival third of 10, where the blue is sticking through, but the embrasure is okay. 7, 8, not so much. We need to prep the distal of 8. 7's actually in the right position already without any preparation. So we could do all of our reduction on the distal of 8 to get there. Same between 6 and 7. 6 is okay, but 7 needs a lot of distal reduction. So even though 7 didn't need any mesial reduction, it's going to need heavy distal reduction. And we need some heavier reduction over here on the distal of 11 as well. If we look at facial reduction on, what are we on here, 10, we see that we need to develop some room for restorative material there. The new design's almost co-located with the pre-existing teeth. If we're looking at that cross-sectional image, if we were to prep it where the red line is, that would be much more appropriate for 10. However, if we go over and we look at 7, it's almost naturally prepared. So it doesn't require a lot of reduction on it. 11 needs some reduction on the facial. 6 doesn't need much other than maybe in the gingival third, and you could get away without doing any. You're at 3.35 there, that's doable. So it's a way of showing in very detailed analysis where teeth need to be prepped, so we aren't just randomly taking away more enamel than necessary with more aggressive preps than necessary. If we want to control that, we can also do a prep through technique from that matrix. Here's what the design looks like in the patient's face. Here's a printed model. And we'll go ahead and make a matrix from the additive only printed model. And we'll take that in the mouth with something like Lexitemp That's what the provisional is going to look like. We can go ahead and check our bite relationship at this stage if we want to. Make sure everything else is approved. This could be a motivational mock-up that the patient could wear if we wanted to do that. We could mill PMMA overlays that would give us the same output that would fit over the existing teeth. So lots of different ways to go. Lots of different depth cutting burrs, whether we use an end punch like Frankie does or one of the other two designs there. We want to know what we're cutting into and how much. In this instance, we're going to see that a lot of this is clearly cut into the left bump and doesn't touch the tooth hardly at all. In other areas, we're going to see heavy reduction of the tooth. So he's going through and doing all of his initial preparation dot. Once he has that done, he'll come back through and prep off any of the marks where the depth punch burr hit the tooth until he gets his final preparation, which in this case looks like this. 8 is a little more chromatic, so he added a little extra thickness to 8. We'll communicate the color of the preps always with the stump die photo. And we'll take photos of the patient in provisionals. So once we get the patient in provisionals, we want to make sure that our occlusion is good so that we can check occlusion digitally as well. We want to make sure that we have good photos looking straight into the camera. It's critical for digital design that we see the face straight on. If the patient cocks their head like I am right now, a little bit this way or a little this way, I can correct that. But if they look left or right, there's no correction for that. So I look at the corner of the eyes to the hairline, the temple area, and make sure I'm seeing the same amount on both sides. I also want to be seeing buccal cusps of teeth back at least to the second bicuspid, because we need those common data points to align. So David, here's the bite on the left video.
Hey Matt, just wanted to show you where CR was here. So that's pretty solid. We got contacts in the anterior and posterior. Worked out real well. Thanks.
Oh my God. I'm not gonna know what to do. I can might eat.
You're gonna smile frequently.
So anyway, we did hit the bite fairly solidly on that. That was without adjustment from a CR position. And she was obviously lit up about it. So now, essentially, our goal is what, Mike? Follow the provisionals?
Follow the provisionals. And I'd like to add into the full face photo part. I also, on mine, I always like to see the tip of the chin and the top of the head. That's straight on. That will allow you to see any facial asymmetries as well and be able to get you're most likely to get your midline at that point in time. So when they're cut off here and here, you're only relying on your eyes to ears and then your nose to the bottom of your ears. If you can see the top of the head and the tip of the chin, you're more likely to get a straight midline.
Yeah.
Just wanted to add that in there.
Yeah, a lot of people have one eye that's a little skeletally lower, or a long ramus and a short ramus of the mandible, and some distortion within their face. So we're always looking for the aesthetic midline that balances that out when we're setting everything up.
Exactly.
So final design is simply using the tools that we have to follow the midline. So we've got a trios impression we can look at from a couple different angles. There's Frankie's preps. And we have a temporary model and an opposing model. So we want to align the temporary model with the prep model. We're going to use what? 3-point
alignment.
So retromolar pad to retromolar pad. If I have hard tissue, I'll use it. Here, the lingual of the central was in a perfect spot to go ahead and pick on both, and then we'll come back and do retromolar pads again. So once we have those spots picked, we'll hit align, Everything comes together, and we look for any distortion between the two models. This is the first place distortion shows up. But look what happens when I turn the translucency up. We see exactly where the preps are within the temporary. So we can see areas that are thin on the temporary. We can do cross-sectional analysis. This would be a wonderful thing to do chair side before you take your final impression, or before you fully provisionalize the patient. Actually, you'd have to have the patient provisionalized to get this, but it's a quick way to evaluate preps.
Use the wax up.
Yeah, exactly. So mesial of 9 is going to be a little bit of a challenge there still. We knew that going in with that lingual placement and the diagonal slice that's going to be required. But you'll see how we get around that. Everything else looks really good. So our initial design, again, we'll bring the teeth in. This is just a quick tour. We're going to do this at super speed. We'll bring the teeth down. We'll turn the temporaries on, make them translucent. Now I move the final design right into the temporary position. I can use the anatomy for reuse file if it's not too beat up, and go ahead and line everything up with the provisional. If I need to, I can also design with a fresh library if the initial diagnostic design wasn't absolutely ideal. But you can see all the teeth are just moving in. The little red spots are occlusal marks on the teeth. We can see where the temp is. We can see where our final design is. And then we'll just move everything together. Now we'll take the temp and the photo of the temp, and we're going to use the 4-point facial alignment again. We'll straighten the photo out. And we've seen this once before. We put the midline in. We can see her midline is physically off to the right a tiny bit. We'll go ahead and make that correction if possible, but we also know where the margins are of the emerging teeth, so we can evaluate that. We can go ahead and create a translucent opening in the picture for a design, and then we can use our 4-point alignment, picking common data points, and that goes ahead and brings that into her full face photo. We check our alignment if we need to. We can tweak a little bit as we are here. I'll move one of the dots a little bit until we have exact alignment. It has an AI function in the software, but it still needs a hand tweak a little bit to get it to align perfectly where you want it to. And once that's done, we'll bring the design in, and we can finesse the design and go ahead and get everything that we want done with that aesthetically and functionally. We can look at our upper and lower. We can go back to our articulator, change to the Stratos, and go to facially generated positions. Get everything leveled with her ears and eyes. And once everything is put together, we can go ahead and run the articulator through its motions. You see we have our lower teeth as well. So now we're getting all of our functional movements. Then we can look at that outside the articulator. Oops, sorry. My apologies there. I clicked through a video. Yeah, there we go. So we can start increasing our cuspid guidance over on 6 and getting it off the bicuspid on 11. Just a matter of adjusting a little bit until we get everything where we want it. Once we have everything where we want it, we go ahead and move forward with the case. We have a little high occlusion spot in a place or two there. We'll go ahead and do an auto adjust feature on those. contacts with digital are really cool. You can slice between the two teeth just like you would run a razor blade through warm wax. And if you watch this video real quickly, you'll see me draw a line that will turn into a disc that cuts on both sides. And it turned red, which means it's hitting a margin in this case. So I'll move it to a more diagonal position and I'll scoot it over a little bit. When it turns blue, it means that we have a clean slice, and we'll go ahead and take the slice. So we make sure that that's vertical and going where we want to. If I turn translucency up on one side of that, on the arch, we look at that, it's perfect contact. We don't ever have to adjust it as long as we don't put glaze on it. And in zirconia, I would say we get zero adjustment on those. In lithium disilicate, we have just a tiny, tiny bit of messing around with them. But by and large, you can pick up a whole pile of restorations that just came out of the mill for a full arch and put them all on the model and really not have any contact adjustment to do, which is really cool. When you go to the midline, we're slicing laterally just a little bit, but we always check that with the facial photo with the lines brought up. So our vertical axis of the midline, we want to make sure our slice is perfectly lined up with that before we actually slice the midline. And we want to make sure that our horizontal plane follows the correct horizontal plane as well. So there's essentially our final design. We'll go ahead and mill that in lithium disilicate. That's what it comes out of the mill like, and that's what I meant by contacts being fairly concise. At that point, everything drops down on the model. We'll go ahead and hand finish that, do any little internal adjustments that are necessary to get it fully seated and make sure that our contacts are good. In this case, I did a micro cutback for layering. I probably wouldn't today. And we'll use a little bit of a stain at the interface. You can see the color that I generated on the interface is really a nice enough translucency pattern that it's not going to accomplish a lot to put enamel over the top of that, but it still comes out looking decent with a little bit of layering porcelain over it. Lower teeth are stained and glazed. There's our final case. And clinical.
So Julie, can you tell me a little bit about this process that you've been through and how it's changed maybe your self-esteem and maybe the way it feels to chew and smile too?
Sure. Well, I knew that there was a problem with my bite. It was really difficult to chew anything. And I had absolutely no idea how horrifically insecure I was about my teeth, visually, aesthetically, until this whole process started. And immediately, my family, loved ones, they started to know not only did I smile more, but the way that I talked, the way that I presented myself, it just kind of made everything sparkle and shine, and not just my teeth. I started kind of smiling from the inside.
So how does it feel to be able to actually get your teeth together again?
I still feel like there's food caught in my teeth because I'm not used to having molars that touch. I chewed a piece of gum with molars for the first time last week in about 18 years. And it's the littlest things like that that are completely life-altering.
So what about the way things look and the final result? What do you think in the end?
I didn't think that it was possible. I really didn't, and I thought it would take years and years and years to happen. It's kind of a miracle. I'm really excited.
Thanks, Julie.
So that's digital workflow from A to Z on one patient with a fairly straightforward, simple case, just really showcasing the tools. What I'd like to do now is step into more complicated cases and some different applications for this. This is a patient that we did a full implant design on. This is a case that Jim Fondries from Chicago did the dentistry on. This is an all-on-6 upper case. So our digital design with pink aesthetics is set up. In this case, we were still cutting back at this time for micro layering. This was just when we first started using the Mio material, and we were using it as an interface stain and then just doing a clear layer of enamel over the top of it. The pink aesthetic on this is all done with Mio. So structure and Mio on the gingival half, cut back micro layering with the Emax porcelain on zirconia for the occlusal. So again, we're really careful with the design to keep the 1200 megapascal material touching the opposing arch and the 85 MPa material not touching. But that's what we ended up with for her. So let's look at our tools again and analyze and think through something that we talked about at the start of this. How accurate is a scanned model, and how accurate is the superimposing ability with 3-point alignment? So to test this, Mike and I scanned the same model twice. Basically, we just went ahead and scanned it 2 times. We called one a provisional and one a prep, and threw it into 3Shape, and we superimposed it. As you can see, the speckly surface is co-locating both models exactly. There's no distortion at all between the two. And if you do a cross-sectional analysis of that and you blow it up to where it fills up the whole computer screen, it's still essentially the same line. There's very, very little space in there. So super accurate process.
It's amazing to see how much warpage there is between the temp model and the prep model. So as we look at this, see how everything kind of moves, and these were lined up with 3 hard points, but there's that much volumetric difference between the provisional and the
so
prep.
That was a scan of 2 analog models, one a temp model and one the prep model, but there was a massive amount of distortion between the 2. We wouldn't have known that if we weren't superimposing the models over each other. If you just held them up side by side, they look the same. But this is why for years when we do wax injections, sometimes the injections were good, sometimes they weren't. And I'm not saying that all analog impressions are that inaccurate. It's probably something that was separated from the tray on the patient's back right on one of the 2 impressions, I would guess, on this. But we see this time and again, and it's one of our most frequent calls. I don't know, Mike, once a week or twice a week, where we're saying that the temp model and the prep model have different dimensional capabilities. Take a look at the cross-sectional pictures, and what would you like us to do?
That's actually gone down significantly in the last year. Since I would say over 85% of our cases we get in are digital.
Oh, yeah.
So we don't see this as much. What we do see digitally is something called a stitching error. Is that something you're going to get into, Dad?
No, but the result of stitching error would be very much what we're seeing here. It would look like this. It's where when you're scanning, the 2 pieces don't want to connect and you keep rescanning the area. You're much better off throwing that data away and getting one smooth scan that goes around. If a good digital impression happens very quickly, working longer on it doesn't make it better. It actually screws it up. So getting the right data quickly and not fighting with the stitching area gives you better data overall.
Don't overscan, don't rescan, smooth continuous pattern in the way that your particular scanner suggests that you go is usually the best way to do it. Overscanning indentureless areas is where we see this the most, because it doesn't have hard tissue to graft to, so it ends up folding in on itself and essentially warping the entire arch.
Yeah. if you have a long span edentulous area that you're trying to scan, sometimes putting a little bead of impression material or bite material down the surface, something that sets up quickly like bite material. You can put just a 0.5 millimeter diameter bead of that to give the scanner something to pick up and connect data, will help with that. And Michael said it, and I'll say it again, scan in the sequence that your scanning company says you should. In other words, if they say start on tooth number 2 and scan forward, drop down and come back around, follow the pathway, because the computer's programmed to recognize the data coming up in a certain order. If you get out of order and start randomly moving back and forth or doing it in a different scan pattern, you can have problems with that. You don't always, but it's much more likely that you'll run into an error. So let's look at the practical usage of this. So bite analysis and recovery. This is a upper provisional, this is a lower provisional against an upper final case that we were in the middle of. If we get our scanned model of the opposing, which is the upper teeth, and we get our bite registration of the lower preps to those upper teeth, and then we superimpose with 3-point alignment our lower temporary over our lower preps, we should see the same occlusion that the temporary has when you hand articulate it, if the temporary has been adjusted in. Now, the patient has a good bite in the mouth in the temporary, but when we do that, what we're seeing is penetration of the lower anterior teeth into the lingual of the upper. Now, this is super common. Some patients are really hard to get to bite in the same place, even when you're using a deprogramming jig or a Kois jig or bimanually manipulating them. They just go all over the place, and this was one. So you can see it in both the images. It's easier if you turn the color off and look at it monochrome. It becomes much more obvious. If we want to analyze this a little bit more, the patient's in a protrusive position slightly, and a cross-sectional analysis shows the same thing. We can see that we're 6/10 into the lingual of that upper tooth with the lower. Could we build a case there? Absolutely, but she's going to be open in the anterior if we do. So we've got a couple of options. We can get a new bite registration, go ahead and remove the temps and take a new bite registration and try again. The patient's comfortable in her temps, and temps are fully adjusted. So can we do digital alignment of the model? And then we have to figure out how to remount that fully prepped lower case in the right spot on the articulator too. So we have the digital temp and the prep. We can use the copy tool that morphs to the preoperative shape, and we can go ahead and do a quick design on the lower teeth and copy exactly to that provisional. There's different ways of doing this. I'm showing one just to explain the concept. Mike can explain a couple of others because this is his area of expertise. But I went ahead and copy milled a wax lower set of restorations that were exactly the same as the temporaries, but were oriented to fit on the prepped teeth. So we could go ahead and seat those on the prepped teeth, and then we can either get a bite registration from the doctor of where the temporaries are. If we have a temp bite, we can use it. We can also hand articulate with permission to the wear facets that exist, and this thing went together like a bear trap. Once we have the teeth on there, we can go ahead and glue the upper and lower model together and take it into the scanner like Mike was showing you at the first of the lecture, and we can make a new bite registration. So with a scanned new bite registration, by scanning the models of this as they were repositioned, we can go into the order and extract the prep and the opposing, and we can align those to this new bite position, which is in the temp position. So we put the upper and the lower arch with 3-point alignment into the bite registration. We now have it mounted exactly the way the patient is in the patient's mouth. and interacting with the temporaries exactly as the patient interacts with the temporaries. So we can go ahead and make our final restorations and place those in the mouth. There was no adjustment on the case at all. And this is something that we do probably 2 to 3 times a week on big cases.
Mm-hmm. Oh yeah.
Yeah. David, any thoughts?
Yeah. I mean, that's huge. You know, when we do our occlusion courses and we have dentists take bites on each other, even in deprogrammer, I'd say 80% of the time, the patient, which is the other doctor, postures forward when they're actually closing into the bite registration, 80% of the time. And so I imagine you're seeing that as well.
Yeah.
And I mean, this is huge because if this was all analog, the only way to fix that would be removal of provisionals and taking bites. I mean, that's the only way you could do it. And I know you, and we've got some other ceramists on the viewing tonight. You've all had that situation where a doctor forgets to take bites or they're not accurate. And there's no way that you can mount 2 prep models, even if the molars aren't prep. You cannot mount them if they're not, if a correct bite's done. You know, something that you brought up a couple times, which I think if people weren't paying attention, because I see this in the lab a lot, is make sure you scan the palate. The palate and the retromolar pads and the hamular notches, because you need hard tissue. And, you know, I see these scans come through where they don't get enough up in the vestibule. And with your putty matrix, there's not enough to really hold on to. It makes temporaries hard to see. But in this verification of bites and tooth position, getting hard tissue stops, because I consider the palate a hard tissue, right? Or if you don't prep the lingual, the anterior teeth, and then either a molar that you didn't prep, or hamular notches, retromolar pads.
Yeah. Michael, do you want to add to the concept there?
Yeah, that is actually very good information right there, especially since we've been talking about 3-point alignment, and the 3-point alignment is not so much exactly where the computer is orienting it to. It's orienting it to the entire arch, but you're telling it north, south, east, and west, and it's doing the fine details. So getting the whole palate, very important. Any hard tissue spots that we can get, bite material, like you said, if we can get those both in the same spot in the scans, would be nice. And then with remounting now, the version that you showed is actually our original way of doing it. Nowadays, we use this 3-point alignment to the hand articulation of the temps, and we can print a bite right out of that. So we don't need to mill wax anymore.
Right. Yeah, that was an antique technique that we developed a few years ago, but you guys do it now just by printing the temps in their bite position.
Printing the preps in the temp position.
Yeah. You can also go back and get a rescan of the temporaries if there's any question on it. Patient, a lot of times the doctor will get the patient back in and mark occlusion around the arch, and then if there's any adjustment that needs to be done, do a little bit of adjustment and rescan the temps and take new bite scans with that, but don't take the temps off and try to take a prep bite again. We can align to that as long as we have the border areas to do it with.
As well as it has the same data points as well. If we're missing all the palette on the prep scan, this is just as important. So we don't have the right data points. It needs to be on both of them. If we don't get all the information from the prep scan, then there's nothing that we can do with another temp scan.
That's true. Yeah, there are cases where we simply look at it, so there's nothing that we can do with this. We need more information, but we can pull a lot of these out. Some of Frankie Scholl's dentistry again, a little bit of recreational opportunity in our area. So let's look at kind of taking this concept one step forward. And I'll go through this case quickly. We only have a couple of minutes left, unless you want to stop it here, David. I'll leave that.
I mean, spend a little bit of time on it. As long as we end somewhere around 8, we get a few minutes for questions, would be awesome.
Okay, that sounds good. So the story on this patient, I'm showing a concept here, not telling the whole story, but basically she had terminal dentition on the upper, we're going to put her in an implant supported full arch position. She didn't want to have ridge leveling or anything like that done. We wanted to do a transition from tooth supported restorations to implant supported restorations. And so we started with a diagnostic wax up, and we put her in provisionals. Right now, she's in a full arch milled PMMA that you're looking at that was done as a shell temp. And we can see a molar and a bicuspid that are a little bit more opaque. If we look back on, what is that, 3 and 5 are a little more opaque. Those are the shells that are holding it. And she has 2 on the other side that are as well. Everything looks nice in her mouth. So essentially she's in a provisional right now. It's supported on prepped teeth. That was done from a diagnostic and a shell temp and a bridge carrier matrix. Now we can go ahead and scan this in the mouth and scan the position it's in, and we can reuse the design, much as we were just showing in the previous case. We can go ahead and put the scan flags in to switch over to implant loading. And we still have the prep teeth in the scan. We didn't want to take those out just yet. I'll do that virtually in the software. And we'll move her from tooth supported to implant supported in kind of a unique way that keeps everything from losing data orientation with the face and also losing bite orientation. So we have her in provisionals. The provisionals are good. We've kept her exactly where she was in her preoperative bite in a CR position. We've now scanned her with those temporaries in and turned that into a bite registration. And we'll go ahead and use multi-point alignment to introduce the implant model and the opposing model back into that relationship. We'll then go ahead and use the anatomy for reuse file and position that using the temporary scan in exactly the same position that it was previously, check our occlusion, and we'll go ahead and connect it to the implant restorations. And we'll use a virtual prep feature to eliminate the underlying prepped teeth that are holding the bridge currently. So we've gone through and prepped the teeth underneath. We've built a bridge that is implant supported, that's in exactly the same position as the one previously that was tooth supported. And nothing has changed in her mouth. From there, we'll go ahead and do the same thing moving forward with zirconia and finish the case out. But again, it's just keeping that bite registration and remounting things to it can work in a lot of different ways, including in a case like that. Other diagnostic things that are interesting, and I'll quit after 2 of these little guys. Patient is in orthodontic appliances. Can we deband this patient right now? Anybody want to take a guess? Is this restorable in this position? You know, maybe, maybe not. There's not a lot of information there. So what we did was scanned her, and we went ahead and removed the brackets, and then we did facial alignment using the multi-point facial alignment. And we did a quick digital design based on the face. We were able to work around the brackets and get things to line up. Now doing a quick design, putting teeth where teeth should be, disregarding where teeth are, just putting teeth in her smile where they should be. Now we can look at that and analyze where the teeth underneath are. We can turn the translucency on the design up, and we can see that number 8 is distal from where it should be. 9 is right into the midline. If we turn the translucency up a little bit, we see it very, very clearly. Gingival levels on 10 could be intruded. So no, the case is not ready to deband. How can we communicate that to the orthodontist? This series of images that we were just looking at, and we can go ahead and print a model and mill a clear PMMA if we want to. So non-invasive, Treatment planning, again, I alluded to this at the start and I wanted to get through this very quickly. Tissue level predictability for an implant case. This patient was going to have implants in the 7 and 10 position. He was also having crown lengthening done. So this will show some of the various tools that we have. We can work from a trio scan, starting, we can do a diagnostic design, doing teeth over existing dentition. We can go ahead and create a template from those. We're up over tissue, so we can measure from the margin up to the new margin of the tooth, what would be ideal. And we know how much gingiva we're going to have to move. We can go ahead and mill that overlay out of PMMA that will fit right over the patient's existing dentition. And we can give that to the periodontist that's doing the gingival surgery so he can establish biologic width to the new marginal position when he's doing the tissue. Now, we also want to get an implant placed in there at the same time, so we need to gather implant data. So we'll go into the implant treatment planning program, and we can incorporate our trio scans so we have much better surface data in Implant Studio. And we position that. We'll go ahead and put a couple of teeth in place, and these are quick designs initially to place the implants, but then we need to figure out where the margin is going to go and how far to put that implant away from the margin. So we want to establish our implant biologic width. We'll go back to our digital design and we'll measure how much we move the tissue. In this case, on number 8, you see the 2 little dots in the cross-sectional pictures show that we moved tissue 2.1 millimeters from where it currently exists. 9 is 2.3 millimeters. We write that down. We record it on the cuspids as well. And then we use the same tool in Implant Studio. We use a cross-sectional tool, and we go up 2.4 millimeters on the central, and we use that as a reference point to have tissue hit tooth for the implant. So once we have that emergence position of the tooth in Implant Studio, then we can go 4 millimeters in and set the implant itself in the right position to result in healthy tissue. At that level, we can build a surgical guide for it. Once the surgical guide is built, we can go ahead and print that. We can send out the whole planning report. And at this point, if we wanted to, we can go forward and design temporaries for the implant. Our rotation's a little bit funky with that, but it works fairly well. And we've done all this planning and treatment planning. We haven't touched a tooth yet on this patient. So the power of treatment planning for stuff like this is amazing. The patient hasn't had anything done yet. Now we can get surgical guides and go in and have everything done. And there's, he only chose to have 4 teeth treated. And this is still not fully healed up yet, but it's a preliminary photo of that. So the point I wanted to make was that you have very powerful case planning tools, whether you're prepping teeth or not. They're amazing to work with.